So you'll be able to see which concepts are associated with multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome is an alteration in organ function. Basically, it's a progressive organ failure. It occurs in patients that are acutely ill, and with these patients that are acutely ill, the organs are at a point that they are no longer able to carry out their functions or maintain homeostasis unless there is intervention. Even with intervention, if certain qualities are not met, then the organs will continue to fail even with that intervention. And I'll discuss a little bit more about that later. Multiple organ dysfunction syndrome is progressive. We also look at it as being 2 organs or more that are failing. And it primarily occurs usually because of an injury or an insult that leads to some impairment of perfusion or ischemia. The impairment of perfusion that is most common when we see this is shock states that we discussed previously. As we know, with any shock state, that's a decrease in perfusion, and the decrease in perfusion causes decreased tissue oxygenation. So tissues are not able to carry out their metabolic processes in the lack of oxygen, and that results in cell damage or cell death. This schematic shows the progression of multiple organ dysfunction syndrome when we have a hemodynamic state that decreases the perfusion or causes pooling of the blood or damage to the vascular system. That leads to cell anoxia, cell death, and ultimately organ failure. With this organ failure, that also releases or triggers pro-inflammatory cytokines, and that worsens the SIRS, or the systemic inflammatory response syndrome. Cell anoxia leads to cell death, and this leads to cell death in vital organs and non-vital organs. Reduction in function of the vital organs will become widespread. Reduction in function of some of the organs will lead to widespread bleeding, and then the prolonged organ failure will then make it, they will get to the point that it's so extensive that there will not be recovery from that point. And because of the lack of recovery, that does result in the client's death. This is the progression of the multiple organ dysfunction syndrome. With MODS, you don't have a good distribution of volume. Volume is not where it needs to be. It's third spaced, and I'll show you a diagram later of what the third spacing looks like. There's an imbalance of oxygen supply versus oxygen demand. The body is in a hypermetabolic state, and the supply of oxygen to the cells is limited because of the limited perfusion. Over the periods of time, the longer that this goes on, the more likely you're going to have organ failure, and then that organ failure will lead to ultimately death. It's not really a real positive outlook for the patients when we see 3 or more organs to fail. 3 or more organ failure will generally lead to about an 80% chance that the patient will not survive. Multiple organ dysfunction syndrome, there are a lot of things that we really want to do with this syndrome. One of the things that we want to do is we want to prevent it, especially in elderly patients who are at high risk. The elderly patients have that lack of physiologic reserve that comes along with aging, and what I mean by that is that their compensatory mechanisms are not as effective as younger adults or children. And without the compensatory mechanisms, when a low perfusion state such as shock occurs, then they are not able to compensate, and they're very quickly are in a situation where they are going to have cell death and organ damage. The degenerative process that comes with aging and the immune compromise also compounds the problems with the elderly patient. Early detection is a key. We need to screen our patients, especially our patients who are acutely ill and critically ill. The patients with chronic illness are at higher risk. Malnutrition, immunosuppression, surgical patients, and patients with traumatic injuries or traumatic wounds. So what we want to look at is control the initial event, so whatever is causing the state that may lead to multi-organ function syndrome. For example, if it's hypovolemic shock, we want to resolve the hypovolemic shock and restore perfusion, promote adequate organ perfusion, as I was saying, and support them nutritionally. With multiple organ dysfunction syndrome, we see these are some of the systems that I'm going to talk to you about. That what do they look like when they're failing, and what do we need to do to restore their function? With the respiratory system is a patient that is in acute respiratory failure, whether it's hypoxic or hypercapnic failure or both. The respiratory system also failure can present itself as ARDS, which would be the refractory hypoxemia that we see in ARDS and the non-cardiogenic pulmonary edema that we see with ARDS. And what we do with the respiratory system, if they have already started to show failure, is that we do ventilatory support with invasive ventilation and try to make sure that we oxygenate the patient as much as possible. The respiratory system is what we need to support to fulfill the supply side of the equation with oxygen supply and demand. The cardiovascular system, what will we see when the cardiovascular system is failing? When the cardiovascular system is failing, we will see lots of times signs and symptoms of heart failure. So that's going to be decreased cardiac output and decreased perfusion. Also, as the organ failure progresses, we will see a rise in cardiac enzymes. CK&B is the most common one that we will see. The GI system. As the GI system fails, we will see a decrease in GI motility. That decrease in GI motility will result in the patients not being able to tolerate feedings. It also could result in paralytic illnesses. And as the GI system continues to fail, we will actually see an absence of GI motility, so we won't be able to hear any bowel sounds at that point. Renal system, look at the lab values to see if the kidneys are failing. Elevated BB1 and creatinine and a decreased GFR, along with a decreased urinary output, will be good indicators for the kidneys. Hepatic failure, the things that we see with hepatic failure are elevated liver enzymes, elevated ammonia levels, and abnormalities in clotting times, decrease in platelet counts. Neurologic system, as it starts to fail, you'll see confusion that will progress to the patient being lethargic, obtunded, and it can progress to a coma if we don't reverse it. Hematologic system is going to be the decrease in platelets. These patients also may have DIC and increased clotting times. This is what happens. This is the slide that I was thinking about when I was talking about what happens when we third space fluids. The fluid resuscitation that we do for critical illnesses, especially most of our shock states, we have to do the fluid resuscitation in order to promote perfusion. But we need to remember with this fluid resuscitation, we can have some third spacing of fluid. This third spacing of fluid does lead to edema. When we think about edema in the legs and feet primarily, but when we talk about abdominal edema, this is actually gives you a good idea of really what happens with that abdominal edema or that third spacing of fluid. Now this is on the severe level with these severely ill patients. The edema or accumulation of fluid causes an elevated intra-abdominal pressure that comes from the edema from the bowels. This edema can also compromise or compress the vena cava. The vena cava is necessary for us to have adequate blood return. It's good flow through the vena cava. So this compression of the vena cava can then reduce blood return to the heart or reduce preload. A reduced preload is going to result in reduced cardiac output. So this compounds the problem that we have with patients that are in low perfusion states if they get too much third spacing of fluids. This reduced cardiac output will reduce the blood flow to the organs and the multisystem organ failure. So this is the vicious cycle that we get into with this multisystem organ failure. This is why there is such a high mortality rate that is associated with this. The key to this with nurses is to recognize early things that could cause a patient to go in multiple organ dysfunction syndrome and to resolve those things quickly so that we don't progress to this point. This is just another schematic. I wanted to point out a couple of things on this for you. A couple of things we're not going to worry about. We're not going to go into that deep of detail with it. But this shows about the CNS system with alteration, consciousness, confusion. They can have some psychosis as well. The respiratory system, that if you have a PaO2 that's less than 70, you really need to start monitoring these patients, and an O2 sat that's less than 90. Don't worry about the PaO2 to FiO2 ratio, but the hepatic system, we look for jaundice, elevated enzymes, decreased albumin, and elevated clotting times. Cardiovascular system, obviously we see our tachycardia and hypotension related to the decreased cardiac output, but we also see an altered CVP with these patients. Don't worry about the PaOP. Renal, oliguria, anuria, and increased creatinine. Along with the increased creatinine, we also see a decreased GFR. Coags and coagulation, we see decreased platelets, increased coag studies, decreased protein C, and increase in the D-dimer. Clinical signs, lots of times with these patients, are very similar to the clinical signs that we see with shock. Usually the signs are related to whichever body systems are failing. Restlessness is related to respiratory. Tachycardia is with the cardiac system. Oliguria, obviously, with the kidneys. If the patients have sepsis and their multiple organ dysfunction syndrome is related to the sepsis, then we do see the signs of sepsis as well as SIRS and the decreased cardiac output, decreased blood pressure. They may have, with the sepsis, the development of ARDS, which would cause the respiratory failure, oliguria, elevated liver enzymes, etc. As their multi-organ dysfunction syndrome advances, patients become hemodynamically unstable. They have a loss of consciousness. Their blood pressure is unstable. It is extremely low. Their MAP, mean arterial pressure, is not adequate enough to sustain life. Their edema worsens, hypoxemia and hypercapnia worsens. They have a profound and unresolvable metabolic acidosis, and obviously their liver failure, their enzymes are elevated, and coagulopathies become worse. So with all of this, and at this point, we have multiple organs that have failed. Nursing management, early recognition is the key. Early recognize patients that may be at risk, maintaining oxygenation and perfusion with these patients, developing a plan of care to support organ function. And remember, to support organ function, we have to pay close attention to our mean arterial pressure. Evaluate the patient's progress or lack of progress, and if the patient is progressing, continue with that therapy, but lack of progress, then the plan of care needs to be evaluated and new interventions need to be initiated. Some of the interventions that we will look at with prevention of oxygenation and prevention, which means that we need to maintain oxygenation and perfusion. So at all times with our patients, we need to maintain adequate oxygenation and adequate perfusion in order to avoid the development of multi-organ dysfunction syndrome. Manage and control any damage that is occurring. For example, when I talk about that the organs are not able to maintain homeostasis, kidneys are one of the ones that comes to my mind. And what that means is that while the kidney is not able to maintain homeostasis itself, these patients may need dialysis. And they're going to usually need a CRRT type of dialysis until we can adequately supply the oxygen and perfusion back to the kidneys so that the kidneys then can go through the stages of acute kidney injury and start to recover. We want to provide information and support to the families. Families always need to be made aware of what's going on. The healthcare providers should have frequent conversations with the families to let them know about the patient's progress or lack of progress. And as nurses, we should reinforce the information as well as give the families the emotional support that they need. Give the families time to discuss what's going on and time to spend with their family members. End-of-life decisions will need to be addressed if multi-organ dysfunction syndrome progresses, and most of the time what we mean by progresses, if there are 3 or more organs involved, then the outcome is quite grave at this point. So this discussion initiated by the physician is lots of times the nurse is going to have to clarify or call the physician back to answer more questions to the family as they process through what kinds of decisions that they need to make and when they need to make these decisions and when they're ready to make the decisions. So we need to be that advocate for our patient's family at that point and make sure that they have the information that they need and contact anybody that they need to talk to at this point. Other contact people that we would obviously get involved with this would be the case manager and chaplaincy services. So with multi-organ dysfunction syndrome, we want to make sure we limit patients' exposure to activators of this. And activators, we want to aggressively avoid shock states, if at all possible, with our patients, and early detection with prompt treatment. Prompt treatment of infections would avoid the progression of sepsis, is an example. Prompt treatment of hemorrhage to avoid going past initial stages of hypovolemic shock. Make sure that we have adequate O2 delivery for the patients and make sure that our treatment is aggressive. We want to protect all of our patients' organs. The way that we protect our patients' organs is to maintain that oxygenation perfusion, that oxygen supply and demand. Those are things that are very important for us to protect. And in protecting all of these, then we will be able to save these organs. And remember, with that, we also have to maintain the mean arterial pressure at 60 or 65 or greater. The other thing that I wanted to remind you of, this is the end of the PowerPoint, but I've also put some notes on the PowerPoint, so if you'll pay attention to the notes, they will probably be helpful as well. If you have any questions about this PowerPoint, please feel free to email me. I'll be glad to answer your questions.